Isolated autoimmune thrombocytopenia, also known as immune thrombocytopenia, or ITP, with a negative antinuclear antibody ANA test, combined with menorrhagia and a general bleeding tendency, suggests a diagnosis that is likely focused on ITP itself, rather than a broader systemic autoimmune condition like lupus. Here are some key considerations for this scenario. 1. Immune thrombocytopenia, ITP. ITP is an autoimmune condition characterized by the destruction of platelets by the immune system, leading to a low platelet count, thrombocytopenia. It is often diagnosed based on isolated thrombocytopenia without other causes and can present with symptoms like petechiae, easy bruising, and mucosal bleeding, e.g., gum bleeding. A negative ANA indicates that it's less likely to be secondary to other autoimmune diseases like systemic lupus erythematosus, SLE. Number 2, menorrhagia and bleeding tendency. Menorrhagia, heavy menstrual bleeding, in a patient with thrombocytopenia could be due to the low platelet count, which impairs normal blood clotting. The bleeding tendency in this setting is often managed by addressing the underlying thrombocytopenia. Treatments like corticosteroids, IV immunoglobulin, IVIG, or thrombopoietin receptor agonists, e.g., L-trombopag or romaplastim, can help increase platelet counts and reduce bleeding risk. 3. Evaluation and management. It's essential to monitor platelet levels closely and assess the severity of bleeding symptoms. Additional workup might include checking for other coagulopathies or von Willebrand disease if there are concerns about the bleeding tendency that might not be entirely explained by thrombocytopenia. Overall, the primary focus should be managing the ITP, especially given the negative ANA. Are there any specifics you would like to explore, such as treatment options or further diagnostic strategies? For a case of isolated autoimmune thrombocytopenia, ITP, that is resistant to pulse steroid therapy, several alternative treatment options can be considered. Managing steroid-resistant ITP requires a tailored approach based on the severity of the thrombocytopenia, bleeding risk, and patient-specific factors. 1. First-line options beyond steroids. IV immunoglobulin, IVIG, often used in acute settings to quickly raise platelet counts, particularly if there is active bleeding. IVIG can provide a temporary boost to platelet counts, but is not a long-term solution. Anti-D immunoglobulin for Rh-positive patients can be used as an alternative to IVIG, but has a risk of hemolysis. It's less commonly used than IVIG, but can be effective in certain cases. Number 2, second-line treatments. If steroids and IVIG do not achieve a sustained response, consider the following: thrombopoietin receptor agonists, TPORAs, L-trombopag, oral, and romaplastim, subcutaneous, stimulate platelet production in the bone marrow, effective for long-term management in chronic ITP. These are generally well tolerated, though monitoring for side effects like liver enzyme elevation, especially with L-trombopag, is necessary. Rituximab, a monoclonal antibody targeting CD20 on B cells, which can help reduce autoimmune activity against platelets. It can be effective in patients who do not respond to steroids and IVIG. The onset of response is usually within 4 to 8 weeks after administration. Consider monitoring for infection risk due to B cell depletion. Immunosuppressive agents, azathioprine, mycophenolate mofetil, or cyclosporin, can be used in patients who are refractory to first-line therapies. These agents are generally considered when TPORAs and rituximab are not effective or are contraindicated. 3. Third-line options. Splenectomy. Historically a definitive treatment, splenectomy is effective in around 60 to 70% of patients by reducing the site of platelet destruction. It is typically considered for patients who do not respond to medical therapy or require ongoing high-dose steroids. The risk of infection post-splenectomy is a significant concern, requiring vaccination against encapsulated bacteria, e.g., pneumococcus, meningococcus. Fostamatinib, a newer treatment option. Fostamatinib is an oral spleen tyrosine kinase (SYK) inhibitor that can be effective in patients with chronic ITP who have not responded to other treatments. 4. Management of bleeding episodes. For active bleeding episodes, platelet transfusions may be needed temporarily, even though they have a short-lived effect in ITP. Tranexamic acid can be used adjunctively to help reduce mucosal bleeding and menorrhagia. Summary of approach: first-line failure, e.g., steroid resistance, move to IVIG or TPO-RAs. Second-line considerations, rituximab or TPO-RAs, potentially followed by immunosuppressive drugs. Chronic refractory cases, consider splenectomy or newer options like fostamatinib. Would you like more detail on any of these treatments or their indications? In newly diagnosed or treatment-naive cases of immune thrombocytopenia, ITP, corticosteroids are typically the first-line therapy. Their role is to quickly suppress the immune-mediated destruction of platelets and increase platelet counts, thereby reducing the immediate risk of bleeding. Here's how steroids are used in this context. 1. Role of steroids. Mechanism. Steroids act by broadly suppressing the immune system, which reduces the autoantibody production and immune-mediated platelet destruction. Effectiveness. They often induce a rapid increase in platelet counts within a few days to weeks, making them useful for achieving initial control of bleeding symptoms. 2. Common steroid regimens. Prednisone. Dose, 1 milligram kilogram per day, up to 80 milligram per day. Duration, typically continued for about 2 to 4 weeks, followed by a gradual taper over several weeks if platelet counts have improved. The goal is to achieve a stable platelet count that reduces bleeding risk, usually above 30,000 per minute before tapering. Dexamethasone pulse therapy. High-dose dexamethasone, 40 milligrams daily for 4 days, is an alternative to prednisone. It is often used as a short-term regimen due to its rapid action and potential to achieve remission in some patients. This regimen can be repeated every 1 to 2 weeks for a total of 2 to 4 cycles if needed. NOSH 3. Response to steroids. About 60 to 80% of newly diagnosed ITP patients will have an initial response to steroids. However, long-term remission with steroid use alone is less common, with many patients relapsing after tapering or discontinuing the medication. If a patient achieves a stable platelet count and is symptom-free, the steroids can be tapered to minimize long-term side effects. NOT 4. Side effects and considerations. Adverse effects. Long-term use of steroids can lead to significant side effects, including weight gain, hyperglycemia, hypertension, osteoporosis, mood changes, and increased infection risk. For this reason, while steroids are effective as initial therapy, the goal is to find a maintenance therapy or alternative treatment to minimize exposure to steroids over time. HERA 5. Decision-making and treatment. The decision to start with prednisone or dexamethasone often depends on the clinical scenario, patient preference, and bleeding risk. Dexamethasone may be preferred for patients where a shorter course is desirable, while prednisone might be chosen for a more gradual approach to tapering. In newly diagnosed ITP, steroids are effective for initial control, but their role is generally limited to short-term use to avoid complications. If there is no adequate response to steroids, or if side effects are unacceptable, other therapies like IVG, TPO-RAs, or rituximab are considered as next steps. Baricitinib, a Janus kinase JAK inhibitor, is not traditionally a first-line or standard treatment for immune thrombocytopenia, ITP. Its primary use is in treating conditions like rheumatoid arthritis and COVID-19 associated cytokine storms, but it has potential off-label applications in treating autoimmune diseases due to its immunomodulatory effects. Here's an overview of its role and potential in the context of ITP. One mechanism of baricitinib. JAK-STAT pathway inhibition. Baricitinib inhibits JAK1 and JAK2, which are involved in signaling pathways that mediate immune responses and inflammation. Impact on autoimmunity. By blocking these pathways, baricitinib can decrease the activity of cytokines and immune cells that contribute to autoantibody production and immune-mediated destruction of platelets. 2. Potential role in refractory ITP. Steroid refractory cases. Baricitinib may be considered in patients with ITP who have not responded to traditional therapies like corticosteroids, IVIG, rituximab, or TPO-RAs. This includes chronic or refractory ITP cases. Mechanistic rationale. In patients with refractory ITP, reducing the activity of immune cells, particularly T cells and B cells, through JAK inhibition might decrease the immune system's attack on platelets. Evidence. There are some case reports and small studies that suggest baricitinib can be effective in raising platelet counts in refractory ITP. However, it is not as well studied as more established treatments like TPORAs or rituximab. 3. Use in clinical practice. Off-label usage. Baricitinib would be used off-label in ITP due to a lack of large-scale randomized controlled trials specifically for this indication. Patient selection. It may be more suitable for patients who have failed other therapies and where there is a need to avoid more toxic or invasive options, such as splenectomy or long-term immunosuppressive agents. Dosage and monitoring. If used, close monitoring for side effects like infections, changes in liver enzymes, lipid levels, and blood counts would be necessary. Doses typically range from 2 to 4 milligrams daily, though specific adjustments may vary based on the individual case. Side effects. Infection risk. Due to its immunosuppressive nature, baricitinib increases the risk of infections, particularly opportunistic infections like tuberculosis and herpes zoster. Thrombosis risk. Although it may seem paradoxical given its use in treating ITP, JAK inhibitors like baricitinib can carry a risk of venous thromboembolism, VTE, which would need to be balanced against the bleeding risk in ITP. Summary. Not a first-line treatment. Baricitinib is not part of the standard therapeutic approach for newly diagnosed or acute ITP. Consideration in refractory cases. It may be considered in chronic or refractory cases after standard therapies have failed, particularly when other immunosuppressive options are unsuitable or not well tolerated. Evidence limitation. More research is needed to establish its safety and efficacy profile in ITP compared to established options like TPORAs and rituximab.